All right, so I don't know if you heard me, Mary, but next week's vascular quiz is going to get pushed back a week. So we're going to do one more week of lecture. All right, so for echo this week, we're going to get into hypertension and congestive heart failure, and then we're also going to jump into some of the left ventricular dysfunction diseases. So we're going to talk about both systolic dysfunction as well as diastolic dysfunction when we're talking about the left ventricle. So these two sections, they're not very long, they're PowerPoints, but it is a lot of information to kind of digest and understand. It's a lot of charts that you also need to kind of familiarize yourself with, particularly when we're talking about diastolic dysfunction. So we're going to start out with hypertension. Hypertension is a term we're all, very familiar with, high blood pressure. But there are a couple of different components, to the reasons why, a patient may potentially have hypertension or be suffering from hypertension. So blood pressure is determined by the amount of blood that the heart has to pump, so that blood volume, as well as the resistance to which that blood flow goes up against. So that's peripheral resistance or resistance within the arteries themselves. So if you think about that, the more blood that the heart has to pump, or the more blood volume, or the narrower the arteries, so that narrowing of that arteries creates higher resistance. This will lead to higher blood pressure. So definition, when the force of the blood against the artery walls is high enough, it will cause health problems, such as heart disease. So this is where you get that term hypertension. So it's an elevation of that pressure within the vessel wall, within the vessel itself, either as a result of increased blood volumes or narrowing of those arterial vessels. And when we're talking about hypertension, there are many people that may actually not even have any symptoms of hypertension. So they're going about their daily lives, not even realizing, that they have elevated blood pressures. And these blood pressures can even be at potentially dangerously high levels. Other patients might experience symptoms like dizziness or headaches. Some patients may develop nosebleeds. So this might be an indication, of a patient who is having a hypertensive emergency. I know I can speak from my own experience with my mother-in-law. She has chronic hypertension that she's, been taking medications for a very long time. She also deals with, has a history of strokes or mini strokes or TIAs. And apparently, she had one hypertensive emergency where she didn't even realize it, and the only thing that signified it is she all of a sudden, developed a nosebleed, and we had to take her to the hospital, and her blood pressure was like 250 over 100 and something, so something crazy high. So just remember, with hypertension, these symptoms usually don't present until the blood pressure has reached a severe or life-threatening level. So, people going around their everyday lives may not necessarily realize, that they're hypertensive. And we're going to see in a second, that hypertension, has really devastating effects on both, your arterial system as well as, other organs in the body, like your kidneys, your brain, makes you more susceptible to develop hemorrhagic stroke, as well as affecting, the heart and its valves. So blood pressures are usually, again, taken as part of a routine doctor's visit. So you guys are all aware with that. Anytime you go to any doctor or urgent care, first thing they're going to do is take your blood pressure. Starting at the age of 18, patients should have their blood pressure taken at least every 2 years. If a patient has hypertension, he or she will probably have their blood pressures checked more frequently. Children 3 and older will probably have their blood pressures taken as part of a normal yearly checkup as well. So when we're talking about hypertension specifically, it can be broken down into two subsets. Patients with primary hypertension, also called essential hypertension, and then secondary hypertension. So this is hypertension that's caused by an underlying condition. So first, hypertension, primary hypertension. So this is going to be idiopathic for most adults. So again, this is hypertension that has no identifiable cause. Primary hypertension tends to develop gradually over the years. And then with secondary hypertension, this is hypertension where we're able to discern, what is the root cause of that hypertension. It tends to appear suddenly and can cause higher blood pressures than primary hypertension. So some of those secondary causes could be kidney problems, adrenal gland problems, patients that have congenital defects in their blood vessels, some patients who have perhaps like a coarctation or potential, like fibromuscular dysplasia, patients who suffer from any type of arteritis. There's certain medications, that can affect blood pressure, like birth control pills, cold medications, nasal decongestants, some over-the-counter pain relievers. You also have to remember, there's also illicit drugs, that patients could be on, such as cocaine or amphetamines, that can cause hypertensive emergencies. And also be cognizant too that there are medications that can cause opposite, you can wind up with patients that are hypotensive as a result. So when we're talking about hypertension, these are going to be our general risk factors that are also, common too when we're talking about peripheral arterial disease. So it's a lot of some of those same risk factors. So we have age. So typically, it's a condition that occurs, and the more elderly you get, the more likely you're to develop hypertension. So there is an age component to that. So as you age, that increases your risk for developing hypertension. There is a racial component that's noted with hypertension as well. The African-American population tends to run a higher risk about developing hypertension than Caucasians. This also leads to increased incidences of stroke and heart attack within those communities as well. So depending on, the population that you're serving in your clinical practice, just be cognizant of that. There's a familial history with hypertension. So again, hypertension, tends to run in families. So if your parents suffer from hypertension, their parents had hypertension, it's a good chance that you're going to wind up, with hypertension, issues with hypertension as well. So it's just something, on a personal level, to just be cognizant of, know your family history and ask family histories, when you're getting a history on your patients as well. There's also correlation with diabetes and being overweight. The more you weigh, the more blood you need to supply the body. So you have a larger body mass. You need more blood supply with oxygen and nutrients. So as your blood volume goes up to meet those demands, this is going to increase, the pressure within the vessels because you have more blood supply. There's also extra pressure on the arterial walls. So you have extra external pressure pushing on those arterial walls as well. So this also adds to increase in the patient's pressure when they're obese. Sedentary lifestyle. So people who are inactive also tend to have higher heart rates, and thus it's harder for the heart. The heart must work harder with each contraction and with stronger force on the arterial walls. Lack of physical activity also increases the risk for being obese. We have to take that into consideration. Tobacco use. So tobacco use, will cause atherosclerosis, hardening of those arterial walls. So this leads to reduced compliance of the arteries, narrowing of the arteries. So this all leads to increase in blood pressure. And then also too much sodium in the diet. So you always hear about people, with hypertensive disorders, I can't have any salt, I can't have any sodium. No, it's just too salty. The reason for that is because you have to think of salt as a lead for water. So I always think of it, where salt goes, water will follow. So if you have too much salt in your bloodstream, you've ingested too much sodium, water is going to follow that sodium into the bloodstream. So then you're now increasing your blood volume, which in turn increases your blood pressure. So that's the mechanism, behind salt raising patients' blood pressures. Some additional risk factors could be too little potassium. So potassium helps to regulate the amount of sodium in your cells. Too little potassium in your cells, and the body will retain too much sodium. Too little vitamin D. Then vitamin D may affect an enzyme produced by the kidneys. So this in turn has an effect on your blood pressure. Too much alcohol. So heavy drinking over time can damage the heart. Drinking more than 2 drinks per day can raise your blood pressure. Stress, so it's always important, maintain your stress levels. High levels of stress can lead to temporary but dramatic increases in blood pressure. So patients going through, a stressful time in their life, or even if they're just nervous, patients who have white coat syndrome, they're nervous about being at the doctor, they're nervous maybe about their tests or their exams. This can cause a falsely elevated blood pressure during that particular moment in time. Patients with certain chronic conditions. So chronic conditions such as high cholesterol, diabetes, kidney disease. Patients with sleep apnea can also increase your risk for hypertension. Sometimes being pregnant can increase your risk for developing hypertension as well. Those are, when you're pregnant, your blood volume actually doubles, I believe, doubles, triples, I forget exactly, but your blood volume goes up as a result of a pregnancy. So that increased blood volume in turn raises your blood pressure. Particularly with pregnant women, they want to have their pressures monitored because you want to make sure they're not running that risk of developing preeclampsia when they're in a hypertensive emergency, because that increased pressure, will also affect the fetus as well, as in addition to the mother, so there could be damage to that developing fetus as a result of hypertension. High blood pressure is, definitely more common in adults than it is in children. Some risk factors in children, could be heart and kidney problems. Again, poor lifestyle habits, such as unhealthy eating and lack of exercise. So childhood obesity, is becoming a real pandemic, here in the United States. You're getting more and more children that are, being diagnosed with, things like, elevated cholesterol, diabetes, as well as hypertension at an earlier and earlier age, So unfortunately, it's a bad setup, for these kids that develop this early in life. It's a hard road to go down once you start aging. If you've already started your life, with hypertension and, poor eating habits and, poor lifestyle habits, it's hard to break those habits when you're young. As you age, I'm sorry. So the excessive pressure on the artery wall actually causes damage to the vessel. So that's why hypertension, is such a serious condition and something that needs to be, really properly controlled and managed. So it damages those vessel walls, as well as damaging the organs of the body. So if you think of the organs in the body, they're vascular, they have a blood supply to them. So you're damaging those small vessels, within those organs themselves, and leads to damage of the organ. In particular, we're talking about the kidneys. That's where hypertension really, can have devastating effects on, because I know here in the lab we have our small chart on our wall showing our kidney vasculature and the filtration system that's involved with the kidneys. So if you kind of pull this off the wall, if you get down at like that small level, like if you're next time you're in the lab and take a look at the kidneys, the whole filtration system that utilizes that the kidneys utilize, all those small vessels in the kidneys, those are the ones where the filtration occurs, and those are the ones that really get damaged, with hypertension, and patient can wind up, with very severe kidney disease as a result of uncontrolled hypertension. And once they start going down that road of kidney disease, that again adds to uncontrolled hypertension. So it kind of just all snowballs on itself, so you damage the vessels, that leads to worsening kidney function. That worsening kidney function leads to higher blood pressures and more uncontrolled hypertension. So it's really a snowball effect when you're talking about the kidneys and hypertension and damaging these vessels. So some other complications we talk about, it could be heart attack and stroke. So hypertension, that damaging of the wall leads to inflammation of that vessel wall, and then healing of that vessel wall. And then you get that repeated process of damage and healing leads to that buildup of that atherosclerotic plaque and that thickening and that hardening. And this leads to heart attack and stroke. The damaging of that vessel wall can also lead to development of aneurysm. So an increase in pressure can cause weakening of the wall, which can lead to a bulging formation or aneurysmal formation. So if that aneurysm ruptures, this could potentially be life-threatening. Hypertension can also potentially lead to heart failure. So that heart muscle will begin to thicken, become hypertrophic. So this hypertension causes the heart muscle to pump harder, leads to thickening. We have reduced internal chamber dimensions if it now becomes thickened. So the heart now has to beat even harder and even faster to try and get more blood out to meet the demands of the body. And eventually this can lead to heart failure in the patient. And so that weakened and narrow blood vessels in the kidneys, this prevents the kidneys from functioning properly. Hypertension can also lead to thickened, narrowed, or torn blood vessels in the eye and eventually lead to vision loss. Patients can have metabolic syndrome. So this is a cluster of disorders that affect the body's metabolism. And then patients have also been exhibited to have issues with memory and understanding. So uncontrolled hypertension might affect your ability to think and remember and actually learn. So these are a list of some treatments and medications that are widely available and utilized to help patients control keep their hypertension under control. So the first one would be thiazide diuretics. So this is medications like Lasix. So you might hear a patient refer to, I'm on Lasix. This could be taken either intravenously or in pill form. So these are medications that work on the kidneys to help patients to eliminate sodium. So like we said, where sodium goes, water will follow. So they help them to eliminate the sodium and by effect, eliminate water. So these are patients that, they're always peeing a lot. You'll get these in the hospital, particularly patients that, have excess fluid on them. They have big swollen legs, the doctors in the ER might give them an injection of Lasix. And all of a sudden, oh God, I gotta pee in the middle of your exam, and they're jumping off your table. That's because, they're trying to get the sodium out of the body and the water's following that sodium, trying to reduce that blood volume to try and lower their pressure. You can also have medications like beta blockers. So beta blockers, this reduces the workload on the heart and opens up the blood vessels. So that dilation of blood vessels causes the heart to beat slower and with less force. We can also have angiotensin converting enzymes. So these are what are called ACE inhibitors. These medications help to relax the blood vessels by blocking the formation of a natural chemical that narrows the vessels. So this is considered a vasodilator. We can have angiotensin II receptor blockers. These help relax blood vessels by blocking the action and not the formation of a natural chemical that narrows the blood vessels. Just another medication, that helps to help with vessel constriction, preventing vessel constriction. We also have calcium channel blockers. So this helps to relax the muscles of the blood vessels. And some also slow the heart rate. We can have medications like renin inhibitors. So these actually work on the kidneys, so help slow down the production of renin. So this is an enzyme that's again produced by the kidneys that stops or starts a chain chemical reaction that leads to high blood pressure. So it slows down that renin production. So if you go back to your A&P, you have your renin-angiotensin system with the kidneys, and that's how the kidneys, again, are responsible for regulating a patient's blood pressure. So these renin inhibitors help break that chain reaction of that production of renin, and this helps to control our blood pressure, help regulate and control blood pressure. So some patients might be on a combination of these medications. So if the previous mentioned drugs do not lower blood pressure, doctors may also prescribe alpha blockers. These help reduce nerve impulses of the blood vessels and thereby reducing the effects of natural chemicals that narrow the blood vessels. You have alpha beta blockers. So this helps reduce, again, nerve impulses to the blood vessels, slows the heartbeat, to reduce the amount of blood that is pumped to the vessels. Central acting agents, so these prevent the brain from signaling the nervous system to increase the heart rate and narrow the blood vessels, as well as certain vasodilators that work directly on the muscles of the wall, again, preventing the muscles from tightening and arteries from narrowing. So separate from medications, the main thing that you can do and have your patients do is, change your lifestyle. So all the things that the doctors tell you to do, eat healthy, exercise, watch your salt intake, quit smoking, reduce stress, do yoga, do something, that makes you happy, enjoyable, set aside some time from yourself. Don't become an alcoholic, to limit your drinking, So all those changes, will have a direct impact, on your overall health, as well as affecting, your hypertension. So you may encounter the term called resistant hypertension. So this is hypertension that's difficult to get under control, despite using several drug therapies. So this might be a patient that has uncontrolled hypertension, even though they're on all these medications. So people with controlled hypertension that are taking four different types of medications. So this is still considered resistant hypertension. So even though your hypertension might be under control, if you're on 4 different types of medications, this is still considered resistant hypertension. So resistant hypertension is hypertension, that's resistant to medications and drugs. So even if a patient has it under control, if they're taking 4 or more of these medications, it's then considered resistant at that point. So then we also have the term congestive heart failure. So you're going to hear this a lot, as you're working, this patient has CHF, they have CHF, they're in congestive heart failure. So what does that specifically mean? So that term congestive heart failure refers to a heart that doesn't have the ability to pump out necessary blood to the body. So a lot of the different pathologies that we learn about can lead to a patient, going into or entering into this disease process called congestive heart failure. So with congestive heart failure, the body does not have as much power to circulate the necessary blood. Blood moves throughout the heart and the body at a slower rate, and pressures increase in the heart. So as the pressures are increasing in the heart, as a result, the heart cannot pump enough blood, out to the bodies, into the organs. So those body tissues and the organs aren't receiving enough oxygen. They're not receiving enough nutrients. So that's why congestive heart failure, is, ultimately, a fatal disease, because the body isn't receiving the oxygen that it needs. The organs aren't receiving the oxygen it needs. It's not receiving the nutrients that it needs. So the heart's going to respond, to this increased demand by trying to stretch more to fill more blood, to try and get more of the blood out to the heart, or either by becoming stiff or thickened. So it's either going to, dilate to try and hold more blood to get that blood out. So if it has preserved systolic function, the heart's going to try and dilate, get more blood in to try and pump that extra blood out to meet the demands of the body. Or if it doesn't have good systolic function, the heart's going to try and either become more stiffened or thickened to try and force that blood out itself. So if it doesn't have that ability to contract, it's going to become more thickened to try and, what comes in is going to try and force it back out to try and keep that blood flow from circulating. The heart walls may weaken and not be able to pump as efficiently as previously. The kidneys are going to respond by retaining more sodium and water. So the kidneys are going to try and, it's going to realize, like, hey, we need more blood flow, more blood demand. So it's going to try and increase that blood volume to keep that forward flow going to meet the demands of the body. So the kidneys are going to respond by retaining more sodium and more water. Patients with congestive heart failure, this is why, fluid starts to build up in the extremities, in the arms, the hands, the feet, and the legs. So patients with congestive heart failure, you'll be able to tell they'll have lower extremity edema. They'll also have fluid buildup in the lungs. So you might be able to you're going to be able to visualize pleural effusions on these patients. And other parts of the bodies will also become congested as well. So again, congestive heart failure is the term that's used to describe, this general condition of, congestion. They have pulmonary congestion, they have peripheral edema, they have congestion within the heart. The blood flow isn't circulating properly, through that heart. The body isn't the oxygen and nutrients demands of the bodies aren't being met because the heart's not beating properly. So some of the causes or reasons why patients might enter into congestive heart failure. So here in the United States, the big one's going to be coronary artery disease, because coronary artery disease is the most prevalent, disease that we're going to encounter in terms of the heart. So with coronary artery disease, that affects blood supply to the heart muscles. When there's a blocked or narrowed coronary artery, the heart becomes starved for oxygen and nutrients, and we wind up with myocardial ischemia and poor cardiac contraction. So a heart attack. So this occurs when the coronary artery is completely blocked. This damages the heart muscle, resulting in a scarred area that does not function normally. Patients can also have cardiomyopathies. So this is damage again to that heart muscle from another source. So we're damaged to that myocardial layer. So again, this could be due to infections, potentially alcohol or drug abuse. When we're talking about or infective endocarditis, something like amyloidosis or sarcoidosis affecting that affecting that myocardial layer. Again, our other cardiomyopathies could potentially be idiopathic. So patients with dilated cardiomyopathy, they have that dilated LV and reduced EF. Patients with the hypertrophic cardiomyopathy, again, they may have stiff, non-compliant ventricles, thickened ventricles. So again, the body's not going to be able to have that, get that demand for that oxygen because that chamber dimensions become quite small now. So also other causes can be conditions that overwork the heart. So like high blood pressure, valvular disease can, significant valvular disease can cause a patient to enter into congestive heart failure, thyroid disease, kidney disease, diabetes, as well as certain congenital heart diseases can all cause a patient to enter into congestive heart failure. Symptoms. There may be no symptoms of heart failure, or symptoms can be from mild to severe. So when we're talking about congestive heart failure, symptoms can be constant or they can come and go. So they can be more transient. There may be certain activities that may induce a patient to develop symptoms. So if a patient has congested lungs, so this is fluid that's backed up into the lungs, this we'll call it shortness of breath, difficulty breathing, dyspnea on exertion, so maybe it's just with exercise. Could be only shortness of breath when they lie back. So lung congestion can cause dry or hacking cough or wheezing. Again, so patients with CHF typically also have a lot of fluid retention. So this could be seen in peripheral edema. So that's that pitting edema. So if you put your finger down on the patient's like leg or arm, you're going to leave an indent or a fingerprint behind. Patients may also exhibit some sort of dizziness, fatigue, generalized weakness. This could be a result. This is a result of, again, those muscles not receiving adequate blood supply. So if they're not receiving that blood supply, you might just feel an overall general, malaise or weakness. That could also lead to lightheadedness, dizziness, confusion. Again, so the body's going to try and get more blood out. So they may have a rapid, irregular heartbeat, heart beating faster, trying to maintain that blood supply to the body. Again, so now we're going to kind of almost switch gears a little bit. So when we're talking about heart failure, remember that, heart failure can either be due to systolic dysfunction or a diastolic dysfunction. So systolic function occurs when the heart muscle does not contract with enough force. Then diastolic dysfunction is when the heart contracts normally, but there's not that proper relaxation of that heart. So this could, be to stiff, non-compliant ventricles or thickened ventricles, and doesn't allow for enough blood to enter into the ventricles during that filling phase. So when we're talking about diagnosis for a patient with congestive heart failure, doctors will perform a complete medical exam, obtain a complete history, including all their current symptoms. Doctors will listen for any types of murmurs. This can indicate, potential valvular disease, valvular dysfunction, presence of any, septal defects. Doctor may order one or more of the following tests. So they'll order blood work, evaluate the kidneys, thyroid function, cholesterol levels, anemia. Within those blood tests, if they're concerned about a heart attack, they would order things like troponin levels, cardiac enzymes. they may order what's called BNP, or B-type natriuretic peptide exam. So this BNP is a substance that is secreted from the heart in response to blood pressure changes when the heart failure develops or worsens. They'll typically order a chest x-ray. So they want to look at a couple of different things with their chest x-ray. First and foremost, they'll look at the cardiac silhouette to see if this patient, has an enlarged heart. They'll also look for the presence of any fluid around that heart, as well as any fluid in the lungs. They'll order echocardiograms. That's where we come in to determine, systolic and diastolic function of the heart. They'll do an EKG. So that's probably one of the first things they'll do as soon as they get into the hospital. They'll throw them on an EKG machine. Look for any abnormal, electrical impulses, any sort of arrhythmias. And then they could potentially send them on for further testing. They may do a cardiac catheterization to determine if, coronary artery disease is the cause of their congestive heart failure. Maybe before cardiac catheterization, they may have them do a stress test where they have the patient exercise to try and determine if there's the presence of coronary artery disease. So with congestive heart failure, we break it down into different stages. So there's different levels or different degrees of congestive heart failure. So our first stage, stage A, so these are actually patients that are just at high risk for developing congestive heart failure. So this includes people, that have hypertension, diabetes, a history of coronary artery disease. Maybe they have some sort of metabolic syndromes, like hyperthyroidism, history of any sort of cardiotoxic drug therapies. So maybe they've, undergone, some sort of radiation therapy for lung cancer or something like that, or history of alcohol abuse, something, or maybe a history of rheumatic fever, family history of cardiomyopathy. So these are, your high-risk patients for developing congestive heart failure. So they don't actually have congestive heart failure at this point. These are just your high-risk patients. So they would fall into that stage A. So these are the patients, that you would recommend to do all the things that your doctor tells you to do: exercise, quit smoking, make sure you treat your hypertension with proper medications, make sure your hypertension's under control. Any cholesterol medications, make sure you monitor your cholesterol, refrain from illegal drug use. Make sure you're compliant with the prescription drug therapies. Don't be like my mother-in-law who decided on her own to stop taking her blood pressure medications and not tell anyone, and then wind up with another hypertensive emergency. Actually, she wound up with a stroke. So my wife, she calls me. She's like, my mother is like acting really weird. Like, she's like just saying things that don't make any sense. I'm like, call 911. She's having a stroke. Like, what do you mean? I'm like, she's having a stroke. Like, call 911. Like she doesn't understand. She's like, she's better now. We're fine. I'm like, no, she's got to go to the hospital. She's having a stroke. It turns out, she decided, because her best friend, who is diabetic, was able to get off her diabetes medications through exercise, that, same held true for hypertension medications. So ambulance shows up, her pressure again is over 200. She had to go to the hospital. This was during COVID. She cursed us out, saying, "You're going to kill me. You're sending me to the hospital because I have COVID." And I told her, like, look, you have to go. You had a stroke. And, they did her full workup. She found she had a little blockage in one of the arteries in her brain. So they, put her on more medications. And I still don't believe, she's really, truly complying with them, because every time I visit her in her house, I find a bag of prescription drugs that's completely full. But, to each their own. I could digress down her road. Like, I got plenty of stories with her, my mother-in-law. Done. But I'll save those for lab. Anyway, so next stage of heart failure is going to be stage B. So these are now people that are exhibiting some sort of dysfunction, so LV dysfunction. These are patients who have never had symptoms of heart failure before. So this is really that first stage of congestive heart failure. Stage A is still considered, the first stage of congestive heart failure, but those are just patients, that are high risk. So stage B is really when patients, are first starting to develop heart failure. So these are patients who have never had any sort of symptoms before. They include patients with prior heart attacks, known valvular disease, known cardiomyopathy. So treatments for patients in stage B, they're similar to stage A. Again, make sure you're following your prescription drug therapy, taking your medications the way your doctors prescribe them. These include patients who now have had surgery for any sort of coronary artery issues. Maybe they've had bypass, stent placements, valvular repair or replacement. So these are patients that, they now are exhibiting signs of left ventricular dysfunction. So whether it's systolic dysfunction as a result of coronary artery disease or dilated cardiomyopathy, or if it's more diastolic dysfunction, restrictive cardiomyopathy, hypertrophic cardiomyopathy, or, or hypertrophic, heart syndrome as a result of chronic hypertension. So progressing from stage B to stage C. So now these patients, that's another thing too. Stage B patients, these patients actually typically don't have any sort of symptoms. So these are patients that we may exhibit some sort of diastolic or systolic dysfunction, but they may not have any symptoms of heart failure. So these are patients who have never had any symptoms. So these patients are typically asymptomatic. Stage C, these are patients that we know have known systolic heart failure or current or prior symptoms. So these are the patients that are symptomatic now. So stage C, we know they have heart failure, we know they have heart disease, and now they're starting to exhibit symptoms. So that's going to be shortness of breath, fatigue, reduced exercise intolerance. So these patients are sicker now. Their quality of life is being affected. When we get into stage C or stage 3, so again, all the same treatments that apply for stage A, the medications that we could administer, lifestyle changes and all that stuff, hold true. But these patients may also require further assistance from things like a defibrillator, cardiac resynchronization. They may also require oxygen therapy at this point, if their shortness of breath has become severe. Stage 4 or stage D. So these are patients now that have advanced symptoms. They also require receive optimal care. So these are patients, that have systolic heart failure in the presence of really advanced symptoms. So treatment methods for these patients are all the ones for A, B, and C, and A, B, and C all apply. These might be candidates, that at this point are viable options, including, heart transplant, ventricular assist devices, or LVADs. They may require, continuous infusions of IV drugs. These patients may also be on end of life or palliative care. So these are the patients that are really, really sick when you're in that end stage of heart failure. So these stage D, these are going to be, your critically ill patients. These are going to be the ones that are, either hospitalized or, require, severe or major interventions, like heart transplant or an LVAD. I mean, these are life-changing, surgeries, that patients undergo. So LVAD is no joke. When you get to that stage where you need a left ventricular assist device, you basically have a mechanical heart at that point, So these are patients that require, major interventions. And, these patients may also be in palliative or end of life care. So stage A, high risk, no symptoms. So these are patients that don't technically have congestive heart failure, but we put them into that stage A because they have, a very high risk of developing CHF due to their histories. Stage B, these are patients, again, that now have new onset of LV dysfunction, but they typically don't have any symptoms. They may have had a heart attack, or they may all of a sudden now have, valvular disease that we first picking up for the first time. So these are those first stage patients, they're asymptomatic, but we know they've had, a prior valvular disease. We're now discovering they have a history of heart attack or valvular disease or cardiomyopathy. Stage C, these are now the symptomatic patients. They have shortness of breath. We know that they have, some sort of systolic or diastolic dysfunction. These are the ones, that require more in terms of intervention. So that could be, again, stent placements, fluid restriction. Stent placements would be for stage B. So this is more invasive procedures like a defibrillator placement. And then stage D is kind of your end of life. In terms of treatment, early steps of treatment include tight control, again, of your lifestyle and medications, being carefully monitored by a physician. The goals of treating patients with congestive heart failure is to control the symptoms and decrease the progression of the disease. So ultimately, that's the goal of any physician is to slow this progression of the disease by controlling the patient's symptoms and the underlying causes of their symptoms. Any questions from anyone about congestive heart failure or hypertension? So hypertension combined with diabetes, that is just like a bad combination for patients when it comes to their peripheral arterial disease and heart disease and risk factors for developing stroke and heart attack. Because that blood sugar, that excess blood sugar, is that sugar molecule is very sharp and does a lot of damage to the inner lining of that wall. Combine that with like the damage done from elevated pressure and hypertension. When you combine the two, you really do a lot of damage to the vessel walls. So unfortunately, it's something that it's controllable. Controlling your diabetes, controlling your blood sugar, and controlling your blood pressures, are something that patients can be proactive on, and really goes a long way to promoting or improving your lifestyle and your overall outcomes, with minimizing the effects that these diseases have on your heart and your body. So like I'm a big advocate of patients who are diabetic and hypertensive, like when they tell me they have these things, I'm like, are you taking care of yourself? Are you doing what you have to do? Like, listen, you got to take care of this, that, and trying to get patients to quit smoking. Like, I know it's hard. I tell them, like, I understand it's hard, but it's something you guys really have to do. You really got to do your best to quit smoking. I guess it's coming more from a city hospital, unfortunately, like a lot of the city hospitals, like those patients are very sick, they're down and out, and their life's hard for them. And I get it, but you really have to convey to your patients, the severity of these things. They don't think high blood pressure is such a severe thing, that it's really going to hurt them in the long run. And it's your job, as good medical professionals and advocates of patient health, to really make them aware of how important it is for them to take good care of themselves. so now, all right, so now I'm just going to kind of switch over into coronary artery disease, ischemic heart disease, and LV function. So again, so coronary artery disease. So this is the most commonly found form of heart disease in the adult community, particularly here in the United States. Coronary artery disease seems to be like a rite of passage for, a 50-year-old male entering into their golden years, like, have you had a bypass yet? Seems like everyone is getting, double bypass, triple bypass, coronary bypass surgery, as they age, because it's just so prevalent now here in the United States when we talk about coronary artery disease. The practice now has become very, I want to say, very fine-tuned, like it's almost like second nature. So heart surgeons now perform coronary artery bypass surgery, have the technique down, and they know what they're doing. They know how to perform it. So outcomes are very successful when we're talking about bypass surgery and CABG. In terms of extending people's lives. I know my grandmother, she had, whatever it was, triple bypass surgery when I was a teenager. So we're talking like, 30 years ago or 20 years ago. 20 years ago, I'm aging myself. So like over 20 years ago. And they told her at that time, oh, your bypass surgery is only going to last, 10, 15 years, So she's about to turn 90 now. So, and she's still doing fine. Her bypass is holding up. No issues. So, coronary bypass is quite common and does, definitely prolong people's lives. And the technique has really, come a long way. So talking specifically about coronary artery disease, it results from atherosclerotic plaque. So that build up a plaque within those arterial walls. There is a hardening of that artery wall as well. So that's the arteriosclerosis. So athero with the ATH is the plaque buildup. Arteriosclerosis is an actual hardening of that hardening of those artery walls. So they go hand in hand. So the syndrome associated with coronary artery disease the syndrome associated with coronary artery disease can either be stable or unstable. Stable or unstable angina. So stable angina is just chest pain, that you're feeling constant, it isn't brought on by, or we know what brings it on. Unstable angina is patients, are exhibiting chest pain that all of a sudden comes out of the blue for no particular reason at all. So that's considered unstable angina. So that's particularly important, when we're talking about patients, when we want to put them through a stress test. So that would be a contraindication for someone who had to perform a stress test. If they have all some chest pain, they're sitting there, oh my God, my chest hurts for no particular reason. That would be considered unstable angina, or attacks come on suddenly and then resolve for no particular reason. Whereas stable angina, we know it's going to cause. When we exercise that patient, they start winding up with chest pain. That's considered stable angina. Some other syndromes associated with coronary artery disease is myocardial infarct, or MI. So that's our classic heart attack. We can also have ischemic cardiomyopathy. So this would be with congestive heart failure, as well as sudden death, sudden cardiac death. So our roles, so echocardiography plays a role in ischemic heart disease by diagnosing, detecting complications, and assessing for potential prognosis. So normal ventricular wall motion consists of both myocardial thickening and endocardial excursion. So to kind of break that down, when we're looking at our LV motion, so we have to understand that the LV is both, when we have contraction, the myocardium, that muscle layer, it's both thickening and moving. So we get almost like a twisting of the heart. So the actual heart contraction motion is a twisting in. So we have excursion motion, like we have both linear and circumferential motion of that heart, as well as thickening of that myocardial layer. So one of the tricks that I use when we're trying to assess EF and looking for wall segment, wall motion abnormalities is, even if a wall is like, moving in one direction, is that myocardium thickening? And that's a much easier way to determine, if a wall segment is down, rather than looking to see if it's actually moving, because the heart's going to move, because say the apex is contracting, it's going to pull that segment upwards that, could potentially be infarcted, that's not receiving the blood supply. So if it's pulling that segment up, it looks like it's moving, but that myocardium isn't thickening. So look more for that myocardial thickening to determine, wall segment abnormalities. So I actually threw a couple of clips on D2L to kind of get you guys in the mode of looking at wall motion segments, wall motion abnormalities, and trying to eyeball EFs. So regional wall motion abnormalities, they occur due to ischemia or myocardial infarction. So, inadequate blood supply reaching that muscular layer is going to cause ischemia. So reduce oxygen demand to that muscle, and that's going to result in wall motion abnormalities. So either, akinesis or hypokinesis of that wall. And then another thing to note is coronary artery disease follows something called an ischemic cascade. So that's going to be here on this next slide. So long before a patient actually exhibits any symptoms, there's perfusion abnormalities that will exist. So we have normal cardiac function. So as the ischemia or the narrowing of that blood vessel occurs, we develop symptoms prior to the patient actually developing any sort of physical symptoms. Before they develop that chest pain or any EKG changes, as that ischemia gets worse and worse, we start seeing some changes prior to the patient actually developing any sort of physical symptoms of chest pain. So we first develop perfusion abnormalities. So the first thing we can actually detect on this ischemic cascade is actually diastolic dysfunction. So that's why diastology and learning diastolic dysfunction is so important, because we can actually, detect ischemic changes within the ventricle prior to, the patient developing any sort of EKG abnormalities or any sort of physical symptoms, and even long before, a patient develops any visible wall motion abnormalities. So that's why, hospitals and ultrasound machines started developing this strain imaging. So unfortunately, we don't have this function on our machines here. I'm going to teach you guys during the summer a little bit about strain imaging. There are some questions on the registry about strain imaging. So that's, we definitely do tissue Doppler. So that's our DTI. So there are things that we can pick up with tissue Doppler. And there are some things that we can pick up with strain, but strain, I feel, is going to be the future of ultrasound, strain and 3D ultrasound. So learning 3D ultrasound and learning strain imaging, it's going to be something that you guys are going to have to, you're going to pick up, hopefully, in your careers and your professions, and learn these things and these techniques. The echo conferences I've gone to are big on strain imaging now and 3D imaging. Because it's very useful for the radiologists when they're doing their surgical, cardiologists and cardiac surgeons when they're doing their planning, to be able to visualize the heart valves in 3 dimensions. We're so used to just seeing everything 2D. So your mitral valve is just 2 little flaps going like that. But the mitral valve, it's very complex when you look at it as a 3-dimensional structure, all the scallops and the actual shape of it. It's more of a funnel shape. To appreciate it in 3D and functioning and visualize, which scallop, where exactly, the regurg is occurring, or which areas are really stenotic, helps guide a lot of the planning. So anyway, so going back to this cardiac cascade, So we're able to determine or see changes, in diastolic dysfunction and strain imaging before we see any sort of visual wall motion abnormalities, and before the patient actually develops that actual chest pain. So the last thing on that ischemic cascade would be the actual infarct or thinning of that myocardial wall and the potential development of scar. So think of this as your degree of flow reduction versus patient symptoms and changes that we see. So we'll pick up changes on the patient's EKG before they're having any physical symptoms of chest pain. Before those EKG changes, we're able to visualize some wall motion abnormalities. And before those, long before those actually are, we're able to detect diastolic changes. So when we're talking about coronary artery disease and ischemia, resting blood flow will actually remain normal until the coronary artery stenosis, or that blockage, actually reaches 90%. So I found that kind of amazing to think that, a patient's coronary artery could be up to 90% blocked, and during rest, that heart is still getting adequate blood supply, adequate oxygen, adequate nutrients to be able to function, even though that artery is 90% blocked. That's a very high grade stenosis. So that's why we do our exercise stress tests, or our pharmaceutical or pharmacological stress tests, to put stress on that heart, to increase the oxygen demands for that myocardium. So we're trying to induce a supply demand mismatch in order to unmask these blockages or these stenoses within the coronary arteries. So we're trying to increase that demand to try and visualize these wall motion abnormalities that might be present before this patient enters into chest pain, and before they have a true myocardial infarct. So before we actually infarct that tissue, and create an MI, or that patient has an MI, we're trying to get them into this position here where we can visualize these wall motion abnormalities when we do that stress echo. So if coronary artery obstruction, so we're talking about a complete blockage now of that coronary artery, persists for a long period of time, usually greater than 4 hours, myocardial necrosis, so death of that tissue, will begin to occur, and a wall motion abnormality would develop. So if blood flow is restored within a relatively short period of time, before that necrosis begins, we'll have some degree of myocardial function will be recovered. In most cases, total occlusion of coronary artery for 4 to 6 hours will result in necrosis of varying degrees. So myocardial infarction. So after an infarct occurs, so this is, myocardial tissue that's gone through a period of time without receiving blood supply. There's a period of remodeling. So the heart's going to reshape itself the way it contracts and remodels. The dimensions and shape of that heart there's going to be changes in the overall dimensions of that heart. So we're going to see in a moment, I have a slide on how the heart remodels. So you get areas of dilatation and bulging in those infarcted areas. So the heart's going to kind of remodel itself to try and, rework itself, to try and, contract properly, to try and, accommodate for those areas that are infarcted and to get that blood out of the heart. The necrotic myocardium is replaced by fibrotic and scars, so fibrosis and scars, so fibrotic tissue and scarring. This fibrotic scarred tissue appears thinner and is more dense than the normal tissue. But important to know that this tissue is unlikely to rupture. because it is more dense. So this scarred fibrotic tissue, even though it's thinner, it's more dense and actually is unlikely to rupture. We can potentially wind up with areas that are aneurysmal. So this occurs in areas that have regional dilatation in the area of the scar. So we get a stretching and thinning of that scar tissue, which leads to an area that's aneurysmal. Areas that are aneurysmal, there's a region of akinesis or even dyskinesis. So that wall motion or that wall may actually go in the incorrect or opposite direction during ventricular systole. Just instead of coming in, that wall motion is actually bulging out. And this leads to abnormal ventricular geometry in both systole and diastole. Regional wall motions, abnormalities due to ischemia usually have normal geometry in diastole and then abnormal distortion during systole. So take into the account. So during diastole, when that heart fills out, the LV, will have that normal, appearance to it. But when it's contracting, that's when you can realize, which walls segments are affected due to, dyskinesis of that, or I'm sorry, akinesis or hypokinesis of that wall segment. So you look for changes in that geometry during systole when the heart's trying to contract. So here's a list of complications that can occur due to a patient who suffered a myocardial infarct. So this is an important list to consider and think of, particularly when you're taking your board exams and your registry, because a lot of the questions they're gonna propose to you, like you're gonna have a list of different conditions, and you have to be able to eliminate, like, all right, that's not going to happen, in a patient with an MI. That's not going to happen, in a patient that has aortic stenosis. That's not going to happen in a patient, that has, mitral regurg, and be able to, select, which the proper answer is going to be. So some complications with myocardial MI, patients can have myocardial stunning and hibernation. So we're going to go over the differences in those two in just a moment. Patients can also suffer from myocardial rupture. So that's an actual rupture of that muscular wall. So if you think about that, that's something that's life-threatening. Patients have acute ventricular septal rupture. So if that myocardial infarct affected the intraventricular septum, we can have holes or rupture in that septum. That could lead to a very large ventricular septal defect and shunting. Patients could have papillary muscle dysfunction or papillary muscle rupture. So those papillary muscles are actually also fed by the coronary arteries. So popular registry question would be which papillary muscle, so we're talking about the left ventricle here, so which papillary muscle is more prone to rupture? So the answer for that is actually going to be the posterior medial papillary muscle, because it's actually only supplied by one coronary artery. So it's only supplied by the right coronary artery. So think of the posterior wall of that heart, the back of that heart. It's typically supplied by the RCA. So that posterior medial papillary muscle is only supplied by the one coronary artery, whereas the anterolateral papillary muscle is supplied by two, either the LAD or left circumflex. So that's less likely to rupture because it has that dual coronary artery supply. Patients can also potentially wind up with mural thrombi. So if you have an area of the heart, that's akinetic or dyskinetic, or even aneurysmal, you might wind up with thrombus, in that particular area. I know we're so used to seeing the ventricle up here, but really that ventricle is down low. So, if you have particularly like the apex is out, not contracting, the blood's going to sit and pool in that apex. So you can wind up with thrombus formation, along that wall that's dyskinetic or akinetic, because you have stasis of that blood. Common finding with myocardial infarct is mitral regurg. So you're going to probably 100% lock it up on your registry. Some question about mitral regurg and patients who've had myocardial infarct or myocardial ischemia. So if, again, you just kind of visualize, those chordae attached to the, mitral valve leaflets. If a wall isn't contracting properly, you're going to have dysfunction of how those leaflets coapt because those chordae aren't, extending properly or contracting properly. Patients will also can potentially suffer from, again, aneurysmal. So aneurysmal walls, you have that thinning of that myocardial layer, which could eventually become stretched out and become aneurysmal. Patients can also have pseudoaneurysms. So this would actually be a rupture in that wall where you're getting extravasation of that blood out of the wall and then becomes encapsulated. So very similar to a pseudoaneurysm that we see within the body. So you would have that yin-yang and bidirectional flow if you were to Doppler in the neck of the pseudoaneurysm. Patients can suffer from something called post-MI pericardial effusion. So this is also referred to as Dressler syndrome. So write that down, Dressler. I'll write it down. Dressler's syndrome. So that's, I don't know if you guys can see that, Dressler syndrome. So that's a pericardial effusion post-MI. So that's something that you could potentially see. So some fluid around the heart. Just remember to use your landmark in your parasternal long axis view for your descending thoracic aorta. Patients can also enter into ischemic cardiomyopathy. Also remember that, you can potentially see RV infarct. So it may not just be an issue with the left ventricle. So the patients could have RV infarct and then look for chronic remodeling of that heart. So, so chronic shape changes to that heart. So myocardial stunning. So this is when ischemia occurs for a period of about 20 to 60 minutes. Function may recover, but not immediately. So this is kind of think of like a mini heart attack almost. So this patient, had a short period where they weren't receiving any blood flow to that myocardium. Then flow was, that heart muscle was able to get reperfused. So maybe they, all of a sudden gave the patient like a nitroglycerin tablet, dilate those blood vessels. We're able to return blood flow to that myocardium. This is referred to as a stud myocardium. So these patients, they recover function of that myocardium. So if it's a brief occlusion of like 5 minutes, these wall motions may recover in as little as 1 to 2 minutes. If the occlusion was for a longer period, say 30 to 60 minutes, we may not visualize full recovery of wall motion for at least 1 to 2, maybe even 3 days. Diastolic stunning also can occur, so this is also a diastolic issue as well. Myocardial hibernation. So myocardial hibernation, this refers to a chronic hypoperfusion of the myocardium. So this is a patient with long-standing coronary artery disease. So, they have, coronary arteries that might be blocked, 92, 93%, almost completely blocked. So a little bit of blood flow is getting through, but not enough. So this is a hypoperfusion, low perfusion of the myocardium over a long period of time. So it can lead to something called myocardial hibernation. So kind of think of like, a bear hibernating during the winter. The myocardium's still alive. We haven't done, complete irreparable damage to it. It's just hibernating at this point. So this is actually considered a reversible cause of left ventricular dysfunction. So we can go in, stent open the artery if need be, or if need be, do a bypass to try and, get better perfusion back to that myocardium. And then we could, eventually over time, that myocardium function is going to be restored. Sorry, just give me 1 second. Well, I'm good. I'm just in the middle of class right now. Sorry. Yeah. All right. So myocardial stunning due to a acute, so this is a myocardial stunning would be an acute process, something that occurred suddenly for a short period of time. We had an ischemia or blockage, blood flow to that myocardium, and systolic function return depending on the duration of that short-term ischemia. It could be within minutes or within days. Hibernation, again, this is a chronic, long-standing hypoperfusion of the myocardium, but this condition is also reversible. So these patients regain myocardial function. We can have a condition called myocardial expansion. So occasionally there's acute myocardial remodeling of an infarcted segment that results in myocardial expansion. So this myocardial expansion will usually occur within the first 48 hours after infarct. This represents acute thinning of that myocardium. So the reason this condition is so critical is so after the patient has an infarct to the heart might try to remodel, and it might remodel in such a way where the chamber actually expands in a certain area quite rapidly. So again, this occurs within the first 48 hours after that infarct. And because that heart expanded and the myocardium became so thin so rapidly, it didn't get a chance to become fibrotic and develop that that fibrotic scar. So that fibrotic scar is very dense. I don't want to say thick, it's dense, it's kind of hard, and that fibrotic scar will prevent aneurysm from occurring. But with cases with myocardial expansion, that myocardium stretched out really rapidly and becomes very thin. Those patients run a very high risk for developing aneurysmal and rupture, so free wall rupture. So it is aneurysmal, but they run a higher risk of developing free wall rupture. So the affected myocardium is thin. Necrotic myocardium with reduced tensile strength can potentially lead to a precursor for free wall rupture, as well as ventricular septal defects and other mechanical problems of MI. So patients with myocardial expansion there have a high risk for free wall rupture or aneurysmal rupture. All right, so now we're talking about wall motion abnormalities. So the location of wall motion abnormality can be a marker for location of ischemia or infarct. So we can use our wall motion abnormalities to determine, again, which coronary arteries are involved. Or again, just be familiar with which wall segments are supplied by which coronary arteries. So we do have qualitative and quantitative measures when we're assessing wall motion abnormalities. So our qualitative would be our eyeball assessment, assessing the walls for normal dyskinetic segments, presence of scar tissue and aneurysmal segments. Semi-qualitative, again, would now be assigning those wall motion score indexes. So we're taking our qualitative assessment and then creating that wall motion score index, which creates a semi-qualitative assessment. And And then we have quantitative assessments of our wall motion abnormalities. That would be our fractional shortening, strain rate, our tissue Doppler, our strain imaging. And then we could do also, so this would be regional assessment. And then we can look at global assessment for our wall motions. So those would be things like EF. Again, some of our tissue Doppler measurements, ejection fraction, volume changes. So qualitative is going to be our eyeball method. So that's, probably the most common method that you're going to be using, just, assessing the ventricular walls, looking for your wall motion abnormalities, which segments are involved, which wall segments, and then correlating that to your coronary artery perfusion charts. So commonly used assessment of LV function is going to be the ejection fraction. So many echo labs will use an eyeball approach. Again, this is highly user dependent. Better method for determining LV volume changes can be used to calculate EF. So that's going to be our biplane Simpson's method. Again, so our biplane Simpson's method, we know we do that in our apical 2 and apical 4 chambers. We're also going to assess geometry of the left ventricle. So just remember, our normal LV should be cylinder in shape with an apical cone or a bullet shape. This can be noted in our parasternal apical 4 chamber and our apical 2 chamber views, as well as in our subcostal views. Our parasternal short axis views should be circular. Abnormal geometry is most commonly noticed in our apical views. So when evaluating for wall motion abnormalities, it's important to quickly assess the geometry, so the shape of the LV, because this can provide some clues to the presence of regional wall motion abnormalities. So this is just a slide showing, a good habit to get in is to assess your ventricular geometry. So this is where it's important, to make sure you're not getting, a foreshortened view. You want to try and obtain a nice, apical 4 chamber view and get your nice cylindrical or bullet shaped appearance of your ventricle. Because again, patients that have any sort of changes in their geometry, this can be an indication, as to where you might be visualizing wall motion abnormalities. So this would be, a patient who probably has some sort of apical infarct. You're getting dilatation of the apex, or the apex appears aneurysmal. You can also, visualize changes too in your short axis view. So just be cognizant, you should have a nice circular walls or nice circular appearance to your ventricle. So again, that's why it's important to be on axis when you're obtaining your short axis views, trying to obtain nice circles, because again, any sort of deviation from that circle could potentially indicate, areas of dilatation. So this would be potentially someone who has got some sort of issues with the ventricular septum. So maybe a septal infarct. So then if you know it's a septal infarct, it's probably more likely going to be your LAD that's involved. So this over here, the dotted line shows, would be a nice circular appearance to your left ventricular wall. It would be a lateral wall dilatation. And also being aware of your, again, your coronary artery perfusion chart. So this is always going to, come back to you on your registry. Just always, practice, be familiar with your coronary perfusions. So we've touched base on this before when we're talking about our wall motion assessments. So we have 17 segments that we assess, 17th being the apex. When we describe our wall motions, they can be either normal, hypokinetic, akinetic, dyskinetic, or aneurysmal. So a normal wall motion score, again, normal, we give 1, hypokinetic, we give a 2, akinetic, 3, dyskinetic, a 4, and aneurysmal would be a 5. And then we add up all the scores, divide by 17, and that'll give us a global wall motion score index. So these are now going to be your main determinants of LV function, or different things that will affect a patient's left ventricular function. So the 4 main terms that we're going to go over are going to be contractility, heart rate, preload, and afterload. So these are the 4 things that determine a patient's left ventricular function. So with contractility, so this is the inotropic state of the myocardium in the intrinsic state of the myocardium, in which alterations can occur independent of preload, afterload, and heart rate. So contractility. So these are the things. So this is how well that the myocardium is able to contract, and the force at which it contracts. Medications like norepinephrine increase contractility, while things like hypoxia, so low oxygen levels, and acidosis, so increase acidity levels within the patient's body, will actually decrease a patient's contractility. So when we're talking specifically about contractility, our main measures of contractility are going to be ejection fraction and that fractional shortening. So that's how we quantify a patient's contractility. So limitations of contractility, determining contractility would be suboptimal images, off-axis images, arrhythmias. So the other determinants of LV function are going to be a patient's heart rate. So the way heart rate, affects ventricular function, in that as heart rate increases, so the reason why we have this statement, heart rate inversely affects ventricular function. So as heart rate goes up, the period of diastole gets shortened. So when we have a shortened diastolic period, we have less ventricular filling. That less ventricular filling, or that lower period of ventricular filling, leads to reduced cardiac output. So that reduced cardiac output means that we're going to have a lower ventricular function. So the higher our patient's heart rate is, the more tachycardic they are, the shorter the period of ventricular filling. So that shorter period of ventricular filling leads to lower cardiac output. It also leads to reduced force of contraction. So we have less stretch. So we have less forceful contractions as well. So that's how heart rate, inversely affects ventricular function. Alterations in heart rate could be due to changes in sympathetic and parasympathetic nerve activity. So also determinants of LV function, preload. So preload helps determine our LV function. So this is, again, just a refresher. Preload is going to be the volume of blood in the ventricles at the end of diastole, so our end diastolic volume. So just remember back all the different things that can affect your preload, your end diastolic volume. So it'd be things like regurgitant valves, so AI, MR, as well as any sort of ventricular septal defects or atrial septal defects. Also, things that affect preload would be your blood volume. So patients that have high blood volumes, like fluid overload, even things like pregnancy. So if you want to think about blood volume, think of like, conditions with pregnancy. Also remember that it could be due to low blood volume. So patients that are hypovolemic, you're bleeding out somewhere that have low volume. So anything that's going to affect preload will affect ventricular function. So just again, remember back to your Planck-Starling relationship. So the greater that LV is going to fill, the stronger that force of that contraction. LV end diastolic pressures increase. As they increase, this results in a more forceful contraction. So that increased volume is going to increase pressures, and that's going to lead to a more forceful contraction. Stroke volume increases. So the amount of blood being ejected increases as an end diastolic volume increases. And then the last determinant of LV function is going to be our afterload. So just a refresher, this is again resistance against which the ventricles must pump against. So those are going to be things like your stenotic valves, so like aortic stenosis, hypertension, so systemic, and also pulmonic hypertension. So don't forget, the right ventricle as well. Could be issues with coronary artery, peripheral resistance. So coronary artery disease. So peripheral arterial disease could be a patient who potentially has a coarctation, so a narrowing of that aorta that's preventing blood flow from getting by. Any sort of impedance in the aorta, maybe even like a blood mass. So could be a patient who has a pulmonary embolism, blocking the pulmonary artery. This could lead to increased pulmonary artery pressures, and you could see strain on the right side of the heart. Systolic function of the heart with normal LV geometry and systolic function. Our linear measurements can be an adequate way to assess the function of the left ventricle. In the setting of regional wall motion abnormalities, our linear measurements are not going to be, may not be reliable, are not reliable. Linear measurements can use only a single interrogation line through the LV, and thus may not be including areas of wall motion abnormalities. So what that's saying is that, what we're doing here in the lab when we do our 2D measurements, our Teichholz, our linear measurements, that's all well and good, if a patient has normal LV geometry and normal systolic function. But if patients, have any areas of infarct, if the LV is shaped abnormally, these linear measurements, are not going to take into account those abnormalities within the ventricle. So that's when we have to use our biplane Simpson's method, to take into account these wall motion abnormalities. And also remember, linear measurements such as M-mode measurements often do not reflect the true minor axis of the ventricle. So oftentimes these measurements can be off axis, particularly true in elderly patients that, have a steep heart. This slide just shows, again, our typical linear measurements that we obtain during systole and diastole that we're practicing here in the lab. And this slide just indicates, the dangers of measuring off axis using the M mode. If you were using the M mode to measure your dimensions, as opposed to doing a linear method, our 2D method measurements. And here they measured the LV internal dimension as 5.5, when in actuality it's 4.5. So the next couple of slides are going to just show some indirect parameters for systolic function of the left ventricle. So if you remember back to our dilated cardiomyopathy, those patients, again, they have a dilated left ventricle with reduced systolic function. So some of the indicators of reduced systolic function is going to be an increased E point to septal separation, that EPSS. So this is going to be on our mitral valve M mode. And we can also exhibit early closure of our aortic valve during systole. And this can also be an indirect measure of LV systolic dysfunction. So patients with poor ejection fraction or reduced LV systolic function. So a normal value for your EPSS should be within 6 millimeters of that left side of the left side of the interventricular septum. And with LV dysfunction, it's increased. So these are both examples of patients that have increased EPSS. So another thing that we can look at too is our M-mode tracing for our aortic valve. So if the forward stroke volume of the ventricle is decreased, so think about it, the forward stroke volume, so like the velocity or the volume of, not velocity, but the volume of blood flow that's being ejected from the heart is decreased. There may be a gradual reduction in the flow during late systole, and this results in a rounded appearance to the aortic M mode. So this is an example. So a nice normal M mode for aortic valve, we should have a nice diameter, a nice box. So an abrupt opening, and then, systolic period, the valve stays open, uniformly open, and then we get an abrupt closure. So if we have reduced ejection fraction or reduced EF and poor systolic function, it opens, we get that blood flow going out, due to those pressure differences. And then the heart is weak, and then we get a gradual tapering of the blood flow due to that poor ejection fraction and then ventral closure. So it takes on a more, I want to say like a pie shape appearance. So you can see it kind of here, you get a tapering or closure of that aortic valve. So our Simpson's rule, or biplane Simpson's method of DIS. This is going to be the most common method for determining LV volumes. Again, this requires obtaining apical 2 and apical 4 chamber views during systole and diastole, tracing those endocardial borders. So we're going to get a little practice tracing to ensure we're not tracing any papillary muscles. This just shows picture, patient sonographer performing the biplane Simpson's method. So you're going to start along the septal mitral annulus, and you're just going to trace up along the endocardial borders into the apex, and then down along to the lateral mitral annulus. And then the machine's going to connect the two annulus. And then you're just going to adjust the peak of that apex, so the caliper up here, so that it fills the entire ventricle evenly, and ensure that there's no areas that aren't being accounted for by one of these discs. Again, so this is done during systole and diastole in both 2-chamber and 4-chamber views. And this will calculate your ventricular volumes as well as an ejection fraction. We doing on time? We're good. So that was systolic dysfunction. So now we're going to kind of shift gears into diastolic dysfunction. So again, this is becoming more and more studied and becoming a larger and larger part of your traditional echocardiac exam. So when I was starting, diastolic dysfunction was just becoming known and becoming more and more with more and more emphasis on it. Now it's a very large part of an echo exam that we do. So virtually all forms of acquired heart disease are associated with a component of diastolic dysfunction. So if you also remember back to that cardiac ischemic cascade, diastolic dysfunction will manifest itself before any sort of systolic dysfunction. So there are 4 phases of diastolic dysfunction. Yes, there are 4 phases of diastolic dysfunction, but remember there are 4 phases of diastole. So diastole again begins during that isovolumic relaxation time or isovolumic relaxation period. So that's the aortic valve is just closed. That signifies the end of systole. We then now enter into the period where the heart is going to start relaxed, but all 4 valves are still closed. So this is the true beginning of diastole. We then have the early rapid filling phase when the mitral valve swings open. Due to the large pressure differences between the atria and the ventricles, we have most of our blood flow entering into the ventricles during that early rapid filling phase. So that usually constitutes about 70 to 80% of ventricular filling happens during that early rapid filling phase. We then enter a period called diastasis. So pressures are starting to equalize between the ventricles and the atria. So we then wind up with a slowing or reduction of blood flow entering into the ventricles. And then we have late diastolic filling. So this represents that atrial contraction or that atrial kick, where the atria contracts and then ejects the remaining 20% of blood, roughly 20% of blood during that late diastolic filling period. So echo evaluation of diastolic function. So there's a couple of things that we're going to look at and we're going to measure when we want to determine a patient's diastolic function. So the first thing is going to be our mitral inflow pattern. So once we get into our apical views, you'll have a real good understanding of our mitral inflow pattern. So this is going to be our E and our A wave. So those E waves and A waves represent the two, represents our different periods during our diastolic flow cycle. So our E wave represents our early rapid filling, and our A wave represents that atrial contraction or that atrial kick. The other Doppler signals or Doppler waveforms that we're going to obtain are going to be our pulmonary vein inflow patterns, as well as our tissue Doppler. So this is going to be our tissue Doppler of our mitral annulus. So just remember, when we're doing our tissue Dopplers, this actually is measuring relaxation of the myocardium. So this is going to indicate our relaxation or moving away from the apex or moving back towards that relaxation period of our mitral annulus. So our tissue Doppler measurements measure velocities and movement of that mitral annulus during diastole. So it's a moving back of that annulus to its resting position. So when we're assessing our mitral inflow pattern, we're going to look at our E to A ratio. So that's going to be critical for us to determine if a patient has any sort of diastolic dysfunction. So we're going to measure our peak E velocity, and we're going to measure our peak A velocities, and we're going to create a ratio, our E to A ratio. So in normal healthy individuals, the E wave is going to exceed the A wave velocity in both. It's going to exceed the A wave in both velocity and volume. This magnitude varies with age due to natural stiffness of the ventricles. In young adults and adolescents, E to A ratios may actually exceed 2.0. In adults over 60, often have an E to A ratio, which is going to be less than 1. So E to A ratio progressively changes with left ventricular stiffening and is due to different pathologies. So this is a nice pulse wave Doppler tracing of our mitral inflow pattern. So you can see a nice, crisp, sharp waveform. So we're going to use our pulse wave because we want to sample exactly in the area where those mitral leaflet tips open at their narrowest point. So we want to get a nice, sharp spectral Doppler tracing. And you're going to measure your peak E and your peak A velocities. And you can also measure something called our deceleration time for our E wave. So you measure along the slope of that E wave from peak E down to the baseline. And that's going to give you your deceleration time. So with our mitral valve inflow assessment for determining diastolic dysfunction. So again, in addition to our E to A ratio, we're going to also assess our deceleration time. So that time, again, that takes to go from that peak E down to the baseline. With grade 1 diastolic dysfunction, we have an increased deceleration time. Grade 2 diastolic dysfunction, this is called pseudonormalization. So in this, we have a normal or decreased deceleration time. Grade 3 is our reversible restrictive filling pattern. And grade 4 is considered irreversible restrictive filling pattern. And this has a decreased deceleration time. Solid. Yep. So this is so stage 1. I'm just going to kind of just break down diastolic dysfunction. So stage 1 is also referred to as impaired relaxation. This is our most mild stage of diastolic dysfunction. So this is kind of when things are starting to get going. Stage 2. So this is referred to as pseudo-normalization. So I'm going to see in a moment why they call it pseudo-normalization. When I was learning it, we only had, to be honest, 3 stages. Our stage 3 was referred to as a restrictive filling pattern or restrictive diastolic dysfunction. But recently they've broken it down into, they separated that stage 3 or broke it down further into stage 3 and stage 4. So stage 3 is called a reversible restrictive filling pattern. Stage 4 is irreversible restrictive. So these are both considered restrictive filling patterns. Irreversible. All right, so I recommend you guys actually like drawing this out. It'll help you to get a good understanding and appreciation of what you're going to be looking for each one. So we said there's 3 things that we're going to look at. We're going to measure with diastolic dysfunction. So first is going to be our mitral inflow. So I'm just going to put MV. Yeah, that's good there. MV inflow. So normal. We have, I'm going to draw it out. You have big E, little a. And our E to A ratio is going to be less than 1.5. So remember we said that some elderly patients can actually have an E to A ratio less than 1. They like to give a range. So we can give a range. So we can say for normal pattern, our E to A ratio is going to be 0.75 to 1.5, but it's always going to be less than 1.5. So E to A ratio. E to A, we're going to say less than 1.5. It's going to be greater than 0.75. So it can be anywhere within that range, up to 1.5 and greater than 0.75. With impaired relaxation, it becomes quite noticeable now. When you do your mitral inflow, the first thing you're going to notice is you're going to have a small E and a big A. So impaired relaxation, you know right off the bat, all right, now this patient has, diastolic dysfunction. So you have small E, big A. And with this, the E to A ratio is going to be less than 0.75. A. It's going to be less than 0.75. All right, so now pressures are starting to build up in the heart, particularly in the atria. So pressures are now starting to increase in the atria. Disease is progressing. Maybe this person has, mitral stenosis. The left atria is starting to dilate more, get larger. Pressures are starting to raise in the left atria. They're going to now enter the next stage of diastolic dysfunction, which is going to be our pseudo-normalization phase. So in this phase, we actually return back to a normal appearing mitral inflow pattern. So with pseudo-normalization now, we're going to have, again, a bigger E, smaller A. And that E to A ratio is going to be the same as normal. So it's going to be less than 1.5 and greater than 0.75. So there's a couple ways that we're going to see in a moment that we can actually unmask pseudo-normalization. So one of which is going to be Valsalva. So we're going to see some changes to these waveforms when we have the patient Valsalva, but just kind of moving along with this mitral inflow pattern. So stage 3 now, This is our reversible restrictive cardiomyopathy or reversible restrictive, I'm sorry, cardiomyopathy, reversible restrictive filling pattern. So here we have a large E and a small a, and it's a significantly larger E wave. So with this E to A ratio, now the E to A ratio is going to be greater than 1.5. Greater than 1.5. With our irreversible restrictive filling pattern, we have a very, very large E and a small a. And again, it's still defined as a E to A ratio that's going to be greater than 1.5. So for this diastolic dysfunction, your E to A, your magic number is going to be 1.5. If you can try and commit that one to memory, 1.5, whether if it's greater or less than 1.5, that's the number that the boards are really going to test you on. So, and then 0.75 for impaired relaxation. So normal E to A ratio, again, it's going to be a little bit, it's going to be anywhere usually from 1 to 1.5. You'll have a bigger E, smaller A. Your impaired relaxation, you're going to have reversal. So you have small E, big A. That's going to be an E to A ratio that's going to be less than 0.75. Pseudo-normalization, you enter into that range again. Then when you get into your late stages or your restrictive filling patterns, you have very large E and small a, and your E to A ratios are going to be greater than 1.5 for both. The other thing that we said we could measure also with our mitral inflow patterns is going to be our deceleration time, or DT, or deceleration times. So again, our deceleration time, we're measuring from peak E down the slope of that line all the way to the baseline. So again, that's going to be that period of time that it takes for that E wave to decelerate down to 0. So that's going to be your deceleration time. So with normal pattern, we have deceleration times that are going to be greater than 140. So DT is going to be greater than 140 milliseconds. When we have impaired relaxation, we have a longer deceleration time. So this slope becomes flatter. So if we're going all the way down to the baseline, we have a longer deceleration time. So with this, we have DT, that's going to be greater than 140. I'm sorry, what? I'm sorry. Yes. So it's greater than 140 still. With pseudo-normalization deceleration times. So they're still going to be greater than 140. So this is where deceleration times now come into effect with your restrictive filling patterns. So with restrictive filling patterns, you're going to have a very short deceleration time. So now deceleration times are going to be less than 140. So this, it's going to be a very sharp drop, not peak E down to the baseline. So you have very short deceleration times, less than 140 milliseconds. And the same holds true with our restrictive. So it's even more severe, less than 140. So to kind of make you guys kind of understand the physiology that's what's going on here. So this is, again, disease that's progressing where the ventricles can't relax and, dilate and receive that blood. So when we think about, the patients that have, restrictive cardiomyopathy or infiltrative cardiomyopathy, as it's getting worse and worse, those atria are becoming larger and larger. So the pressures within those atria are increasing and increasing. So if we have very high pressure within the atria, during that period where that mitral valve first opens, you're going to have a very high pressure gradient. So you have high pressure in the atria, much lower pressure in the ventricles. So you're going to have the majority of your blood flow entering into the ventricles during that early rapid filling phase. So that's why we have very large E waves. So that mitral inflow pattern has a very high E wave, high velocities, large amount of flow going into the atria during that early rapid filling phase, and then very minimal amount during that atrial kick, because the majority of that blood flow is already entered into the ventricles. That's the result due to that very large pressure gradient. So these are patients that have very elevated left atrial pressures. Does that kind of make sense to everyone? Like why we get a very large E with this restrictive filling pattern? It's because they have very high left atrial pressures. So at this point, with impaired relaxation, atrial pressures are still normal. The reason we have a small E is because that ventricle can't really stretch. So we have the ventricular pressures that are actually elevated at that point. So the diastolic pressures in the ventricle rise very quickly because the ventricle can't stretch and relax. So then, since those pressures are rising, fairly quickly during that early rapid filling phase, it ends quite rapidly because you get normalization of those pressures. And then we rely on the atria to squeeze out the majority of that blood. So at this point, the atrial pressures haven't elevated yet. It's just the ventricles that are becoming non-compliant. They're not stretching. So the ventricular diastolic pressures are starting to equalize faster. They rise faster because it can't stretch. So we get only a marginal amount of blood entering into the ventricles during that period. So we have small E and then a large A. We rely on the atria to contract to get the rest of the blood out. Once we enter into pseudonormalization, now we're starting to get those elevated pressures now in that in the atria. So because of those elevated pressures, we now flip-flop back into our normal, into a normal filling pattern, because we have those higher atrial pressures to aid in that early rapid filling. So because of those higher atrial pressures, we now transition back into that a normal appearing mitral inflow pattern. So that's why it's called pseudonormalization. Those atrial pressures are starting to increase and increase now. So we have more and more filling during that early rapid filling during that E wave. So we were actually able to unmask pseudonormalization by having the patient Valsalva. So we remember back also, Valsalva was useful for enhancing a subaortic stenosis or an LVOT obstruction. So when we had the hypertrophic cardiomyopathy, we had the patient's Valsalva to try and enhance or augment that LVOT obstruction to try and determine if a patient has a dynamic LVOT obstruction. We had in Valsalva, or we also had those patients inhale amyl nitrate. But in this case, we're going to have the patient's Valsalva, and we can use the Valsalva maneuver to try and unmask our pseudonormalization. So when we have the patient Valsalva, so this is still mitral inflow, and then with Valsalva, we have a reduction in the amplitude of the ENA wave, but the relationship between the two maintains the same. So we still have a larger E and a smaller A. Just the amplitudes are less. In a patient with impaired relaxation, when they have Valsalva, the waveform is going to look essentially the same. We're going to have small E and a bigger A. So we still have that EA reversal with Valsalva. Now, when we get into pseudo-normalization, when the patient Valsalvas, we'll now be able to demonstrate a reversal. So this normal appearing mitral inflow pattern will reverse into a small E and a large A. So with Valsalva, we now can unmask that pseudo-normalization and we'll take on a impaired relaxation waveform pattern. With reversible restrictive cardiomyopathy, again, so now we're still going to have this reversal for E and A wave. So with these patients, the reason they broke it down into reversible is because, you know, performing this Valsalva maneuver, we can kind of change the flow patterns. So the pressures are still susceptible to our respiratory changes. With irreversible restrictive diastolic dysfunction, when the patient Valsalvas, we don't get any change to that E and A wave. So with Valsalva, we have a very high E and still a small A now. Small. So that's one way we can kind of differentiate whether or not a patient's in stage 3 or stage 4 is with that Valsalva maneuver as well. So in stage 3, we can still like influence our waveform with the Valsalva maneuver. Once the patient's into that stage 4 with irreversible restrictive filling patterns, that Valsalva maneuver, you know, becomes ineffective. It doesn't affect anything. So they still have a large E, a very large E and a small A. So then with diastolic dysfunction, the other thing that we can, one of the other things we look at is going to be our tissue Doppler, or TDI. All right. So our tissue Doppler of our mitral annulus, again, this is measuring diastolic movement of that mitral annulus. So under normal conditions, we're going to measure, our tissue Doppler measures E prime and A prime. So under normal conditions, our tissue Doppler pattern should mimic or be a mirror image of our E and A waves. So our E prime, we should have a large E prime and a large A prime. So it's just kind of like a mirror, the opposite direction. Whereas this measures like our inflow, blood flow going in one direction during diastole. This is measuring the annulus movement. So our E prime and A prime, let me draw this below the baseline. For normal, we're still going to have a large E and a small A. E and A wave. And when we're talking about diastology, what they're going to compare now is going to be our prime, sorry, E prime and A prime. They're going to create a ratio for our E to E prime. So they're going to take what your maximum velocity was on your E wave and your maximum velocity is on your E prime wave and do an E to E prime ratio. So with our tissue Doppler, they're doing an E to E prime, E over E prime ratio. So with this, with normal, it should be less than 10. So what that means is our E velocity, say we got 10, and our E prime velocity should be very similar. It should be like 9, 10. It's usually a little less. But so those numbers should be pretty similar. As long as it's less than 10, that's okay. That's what we want. When we get into impaired relaxation, we now have, again, this is going to be now reversal. So we were able to, again, diagnose, impaired relaxation. We get a smaller E and a larger A. So again, it becomes quite noticeable. So E prime, it's going to be smaller than A prime. But we'd expect that because we saw it on our mitral inflow. So again, so this tissue Doppler should mimic your mitral inflow. So with impaired relaxation, we have small E, big A. Our tissue Doppler again should be now a small E and large A. But when we compare now our ratios, our E to E prime, again, so it's going to still be similar to our normal. It's going to be an E to E prime ratio less than 10. So now when we get into pseudo-normalization and then our restrictive filling patterns, then this is where the values become noticeably different. So with pseudo-normalization now, we're going to have a small E and a larger A. So now if we compare our E to E prime, we have a large E and a small E prime. That's going to give us an E to E prime ratio that's going to be greater than 10. So now we're getting into our restrictive filling patterns. So now if you think about your pathologies, these are hearts that, the ventricles are really stiff. They're non-compliant now. So since those ventricles are stiff, the mitral annuluses aren't moving very well at this point. So since the mitral annuluses aren't moving and this tissue Doppler is measuring velocity movements of that of those annuluses, we're going to have small E and A waves. So our tissue Doppler is going to look very reduced. So we'll have a small E, and a little bit larger A, but very small comparatively, to what we were getting before. So these waveforms are going to be much larger. Once we get into our restrictive filling patterns, I'll make them even smaller to kind of exaggerate. We have reduction of our E and A waves. So if we look at our ratio, we have a very large E wave here and a very small E prime. So this is going to be an E to E prime ratio. That's going to be greater than 10. Did I put greater than? I put less than here. I put less than here. I'm sorry. I'm so bad with these. Greater than E prime. Greater than 10. Same holds true. So this is even more exaggerated. So we're getting even smaller waveforms now as this progresses. And at this point, the E and A waves are almost identical in size. So if we had to, again, do a ratio, our E to E prime, this is going to be obviously greater than 10. E to E prime, greater than 10. Do they do all these things at Christianity? Don't know. Don't know. All right. Do I know? I don't even know if they measure deceleration time of the U wave or anything like that. Probably not. I'm sure they measure peak E and peak A. They might not even measure peak A. So far, does this stuff kind of make sense to understand why we have large E waves, smaller A waves, as those pressures in the atria are increasing? These are numbers that are gonna, eventually show up on your registry exam.
I'm probably not gonna draw it all out again, but the chart is helpful. There's a chart. I saw the chart.
You saw the chart? You should draw the chart. Draw it like me. This is how you learn. I should make that assignment for you guys. I should give you guys assignments, right? Homework?
Negative.
Yeah. It's a no for me, dog. No, but that's seriously, drawing this out will commit it to your memory. Draw it out. Get all chalky and dusty like me. They stuck me a bunch of times today. This person failed. So the last thing we can look at is actually our pulmonary vein flow now. So our pulmonary vein flow will unmask some things as well. I'm just going to erase some of this stuff. Does anyone remember which pulmonary vein we typically Doppler? Anyone? Or how far into the pulmonary vein we Doppler? Did we go over this? I don't know if we went over this, but typically we're Dopplering the right upper pulmonary vein, and we want to be about 1 to 2 centimeters into the pulmonary vein when we're Dopplering. Like Marissa had beautiful pulmonary veins. I think she was the good one, right? So pulmonary venous flow. So normal pulmonary venous flow. Typically, we're going to have pretty normal or symmetric flow during systole and diastole. Normal flow. So I'm just going to say pulmonary vein flow. So our waveform will typically appear like this. It's too big. All right. So pulmonary venous flow is it's pretty continuous. So we get forward flow into the atria, into the left atria during systole. We get forward flow during diastole. And then when the atria contract, we get a little bit of flow reversal back up the pulmonary veins because the atria are contracting. So it's kind of forcing some of that blood flow back up into the pulmonary veins. So you get a little retrograde flow when the atria are actually contracting. So that's your normal pulmonary venous flow. So when you're looking at patients as they enter into impaired relaxation or abnormal relaxation period, first thing we notice is that we get an increase of flow during systole. So that S wave becomes exaggerated or becomes larger than our diastole. So stage 1, we'll put it here. So we have a larger S wave, a smaller D wave. We still get a period of atrial reversal. S, D. When we enter into stage 2 or pseudo-normalization, we actually wind up with reversal. So now we have a smaller S and a larger D. And we're starting to get a little bit more atrial reversal. I'm just going to kind of highlight this in just to signify that we're getting some more atrial reversal compared to the other patterns. When we enter into a restrictive filling pattern, now we get very pronounced D wave. And even more atrial reversal, SD. Even more, and then it just becomes more exaggerated as we move into our restrictive. You get an even larger period of flow reversal during that atrial contraction. Let's see. Extra, I don't know, what do you want to say? An extra 5 points. We'll make this worth 5 points on the next quiz. If I have a pulmonary waveform that look like this during systole, I get reversal of flow. during systole in the pulmonary veins, what would that indicate?
Is that kind of like the flying W, like pulmonary hypertension?
Nope, this is in the pulmonary vein. So pulmonary hypertension would actually be in the pulmonic valve. So if I was doing an M mode of the pulmonic valve, that would be pulmonary hypertension, the flying W. What could cause flow reversal in the pulmonary veins during systole? I know you guys are on Google right now looking it up.
I'm just writing this one down because you just said it was 5 points on the quiz. So
I'm giving 5 points to the person who answers it now.
Is it mitral regurg?
Is that an honest answer or did you Google it?
No, it's honest answer.
Yes, mitral regurg, yes.
Isn't that how they tell if it's severe or not?
Severe mitral regurg, yes. Good. Just jogging your memories. I'm going to do this. I'm going to do a little competitive quiz question answer. Good. Yes. Severe mitral regurg. So systole, mitral valve is closed. We have regurgitation during severe mitral regurg during ventricular systole. So you can wind up with reversal of flow in the pulmonary veins with severe mitral regurg. That's one of the things they look for. Ah. You guys are cursing me right now.
They do use the E and A wave for mitral regurg too for the mitral valve. I've seen, like, because she called me out one time, Michelle, and then we didn't go over it yet. And I was like, I don't know.
Oh, man.
I was like, what does that show? I was like, I don't know.
You go back now and be like, I know this.
Yeah.
I know this now.
Wait, side note, because I didn't get to tell you guys. So when I was talking to Kate my last week at Echo, she said that Jen is going to be out for a little while because she had to get surgery on her foot. And that's why she was limping that day. I know I told you about that. But anyway, so you guys may not have to deal with her. Side note.
Yeah, I go there next, so hopefully she's out for those 3 weeks.
All right. Let's see. What is not a name for an aortic cuff? I think you guys all got that right. Anterior coronary cuff. You know what I can do? That's not. Statistics. That one. So the thick round fibrous skeleton that acts as support for valve attachments, that's going to be your annulus. So severe mitral stenosis is considered when pressure half time is going to be greater than 220. So just remember your equation for mitral valve area is 220 divided by pressure half time. So you want to have a large denominator. So your pressure half time is going to have to be greater than that 220 to get a value less than 1. I'm just skipping the ones everyone got right. An indication for severe aortic stenosis would be a velocity greater than 4 meters per second. If they give it to you in centimeters per second, it'd be greater than 400 centimeters per second. Mitral valve can be considered severely stenotic when the valve area, that's going to be less than 1 centimeter squared. Severe aortic regurgitation is suggested when. So definitely it's going to be holodiastolic flow reversal in the descending aorta. So that's one of the things that you can look for. And then with pressure halftime, with severe aortic regurgitation, you're going to have a very short pressure halftime. So the pressures are going to equalize quite rapidly. So when we're Dopplering aortic valve, so we're going to typically Doppler it, in our 3-chamber or 5-chamber view. So just remember aortic valve flow in that view is going to be away from the transducer. So normal aortic flow velocities are going to be below the baseline. Our aortic regurgitation is going to be above our baseline. So with severe AI or aortic insufficiency or regurg, you're going to have a very short pressure halftime. So it's going to be pressure halftime. It's going to be less than, less than 220. Not 220, less than 200. I'm sorry, 200. So what that means is that the slope of this line is going to be very steep. So that pressure halftime is going to be very short. So the time it took to get for that pressure to decrease by half is going to be very short. So you measure along the slope of that line. Remember, for pressure halftime, you don't have to go all the way down to that baseline. So you're just measuring along that slope of that line. If it's very short and very steep, that's going to indicate severe aortic regurgitation. And also, if your tracing is very bright and filled in, if it's very turbulent flow, as a result of that severe aortic regurgitation, you have a very bright spectral tracing. Whereas with mild AI, pressure halftimes are going to be very long. So you're going to have an extended pressure halftime or very long pressure halftime. So it'll be a very flat slope. And it's going to be greater than 500 milliseconds. And you'll also have a very light or faint tracing for mild aortic insufficiency. So just don't get confused with mitral stenosis, because this looks similar to your mitral stenosis. So this would be severe mitral stenosis. So a long pressure halftime for mitral stenosis and a short pressure halftime for severe aortic insufficiency. So for that, correct answer is going to be that one, the holodiastolic flow. with pressure halftime less than 200. Which of the following is not a secondary finding in patients with mitral stenosis? So for these types of questions, you kind of just have to think what is more proximal to the area of disease or the valve that we're talking about or the chamber that we're talking about. So we're talking about the mitral valve, mitral stenosis. You just have to look at your choices and see what's in the chamber before that or the structures before that. So before or more proximal upstream to the mitral valve is going to be our left atria. So mitral stenosis can cause left elevated atrial pressures, which will cause the atria to dilate. Those patients can potentially have AFib due to that dilatation. They can wind up with stasis of blood or smoke or that what's called spontaneous echo contrast. So that's that precursor to thrombus. So they're more prone to developing left atrial thrombus. If I had put on here, like pulmonary hypertension, that could be in an answer to, or anything on the right side of the heart as well. So the only one that really wouldn't be caused by mitral stenosis would be a left ventricular thrombus, because this is past the valve. So if I had put on here like aortic stenosis, left atrial thrombus could potentially be an option. The blood flow is not getting out. It's really stenotic. You're winding up with potential stasis of blood within that chamber. So that could potentially be an issue with something like aortic stenosis. But left ventricular thrombus, you also have to take into account ventricular function. So that's also an issue as well. So if the patient has normal ventricular function, the likelihood of a ventricular thrombus decreases significantly as well. But you have to just think what's in the realm of possibilities, But I just want you to be cognizant that, disease happens downstream. Just always think what's proximal to that area of disease. So this is showing a pulse wave tracing for a mitral valve. So if you look at your mean pressure gradients, mean pressure gradient greater than 10 indicates severe mitral stenosis. The primary cause of aortic stenosis in the United States, this is going to be degenerative calcific disease. So the calcified, it's going to be degenerative aortic valve disease. It's that calcific aortic valve. The most common congenital defect of the aortic valve is going to be a bicuspid aortic valve. And the most common congenital heart defect, to be honest, is a bicuspid aortic valve, or one of, I want to say PFO might be more common, but the most common congenital lesion for the aortic valve is going to be a bicuspid aortic valve. So based on the aortic Doppler tracing seen below, what pathology can be considered? So that kind of goes back to this chart. So they're showing a pressure halftime of over 800 on a very flat slope. So this would indicate mild aortic insufficiency. LVOT diameter should be measured. So this should be measured during mid-systole from the blood tissue interface to the blood tissue interface. So which condition is a RAFI associated with? So this is going to be a bicuspid aortic valve. So this refers to fusion of those commissures. So we get that in patients that have a bicuspid aortic valve. A cause of congenital mitral stenosis. So congenital means, you know, something that you're born with. So rheumatic heart disease would be acquired, so that wouldn't be a congenital disease. MAC is something that develops over time. Papillary muscle rupture wouldn't necessarily cause a stenosis. In fact, this would be more for mitral regurg. So the only one really is a parachute mitral valve. So that's when all the chordae are attached to a single papillary muscle and creates almost like a funnel for that mitral valve, and creates a stenotic mitral valve. So it doesn't allow those leaflets to open properly because they're all attached to that single papillary muscle. So when using the continuity equation to determine aortic valve area, using the velocity time integral method, what measurements must be obtained by the stenographer? So these are the three measurements that we need to always get when we're trying to use the continuity equation for aortic stenosis. So the first is going to be your LVOT diameter. You're next going to calculate your LVOT velocity time integral. So you're going to use your pulse wave Doppler to make sure you're sampling in the LVOT. You'll get your velocity waveform, and then you're just going to trace along that waveform to get the velocity time integral. And then you're going to use continuous wave Doppler and measure your velocities through the aortic valve and trace the velocity time integral. So you'll trace along that curve and get a VTI for your aortic valve. So it's aortic valve VTI, LVOT VTI, and the LVOT diameter. So what do the arrows in this suprasternal notch Doppler sample point to? So this is our suprasternal notch. If you kind of remember when we were imaging suprasternal notch, we saw our nice little candy cane view. We saw ascending aorta, the arch, and then descending aorta. So this demonstrates aortic flow. That's what we're looking at. That's what we're assessing when we do our suprasternal notch. So the fact that I see this area of flow here below the baseline, so this like nice arterial signal, I know that I'm Dopplering in that descending aorta. So this is the descending thoracic aorta where we're Dopplering because the blood flow is coming away from the transducer. So if I'm imaging from here and I see blood flow going away from my transducer, I know that's in that descending aorta. If I was angled more towards the ascending aorta, this portion of the waveform would be above the baseline. So I'd see my systolic tracing or aortic tracing above the baseline. I know that I'm Dopplering the ascending aorta at that point. So what this is showing is holodiastolic flow. So during diastole, the part between our systole or aortic waveforms, flow reversal. So going in the opposite direction during diastole in the descending aorta. So this would be an indication too of a patient who has severe aortic insufficiency. So that's one of the things that we would look for in our Doppler tracing. to diagnose severe AI. I hope you guys are going like, oh, I see that now. Okay, all right. So based on that previous question, what pathology should be considered? So that's aortic regurgitation. So this MO tracing was showing a B bump. So this is related to increased left ventricular diastolic pressures. Systolic anterior motion of that mitral valve leaflet would be seen in this segment. So during systole. So this is diastole when the valve is open, this mitral valve. SAM would be on this portion, an upward bending or suction of that leaflet towards the septum. Diastolic flutter of the anterior mitral valve leaflet would be seen predominantly during this portion here or across the entire thing. So you'd see like fluttering of the entire leaflet, but this is a fairly nice crisp tracing. So I don't see any fluttering really of that leaflet in that segment. Like you'd see like kind of like little jagged ripples across of it. Prolapse again would be during that systolic portion, like when the leaflet should be closed, a bowing backwards of the leaflets. Everyone's favorite, number 26. So I accepted a bunch of different answers. So what methods could we use to calculate mitral valve area? So you could use polarimetry. So you can actually trace the opening. So you could go to your short axis view of the mitral valve, your nice fish mouth, and trace the opening. We can use pressure half-time method. We can use mean pressure gradient to calculate mitral valve area. We could use PISA now. We have a new PISA technique. We can do max pressure gradient. One of the ones that I accepted a couple different ones. I forget what some of the other people were. Continuity equation. You can potentially use continuity equation if you wanted to. I accepted that as well. Why didn't they even tell me that you guys didn't see the screen? I was sharing the slide.
You were too far in.
Come on, stop me, people. Like, I don't know what I'm doing. Like, speak up. Like, you guys gotta speak up. Tell me. Like, don't be shy. Like, I just wait till I was like, wait a minute. Like, I wasn't even showing my screen. Like,
I thought it was my computer at first, and then when I realized it wasn't,
guys, talk to me, man.
You were too far gone.
We're family. Like, if I got crap on my face, tell me. Like, please. Like,
I thought it was my computer too. I thought I was just having a problem and I didn't want to interrupt anyone. But then I realized like 10 minutes in that it was not me and it was too late.
Yeah, my computer literally freezes and like shuts off. So I was like, oh, it's messing up again.
I'm here going through each question. I'm like pulling it off. I was like, oh, look at this. This is like that. And like which one? This one? Was it this one?
You said, do you guys see this now? And we're like,
Yeah, like here, like
no.
she's the guys. Come on. Gotta tell me these things. It's all right. Mitral waveform. We have a nice crisp, sharp waveform. So this wouldn't be that diastolic flutter. If it was fluttering, you'd see like ripples along the entire anterior mitral valve leaflet.
I
Sam,
still can't see anything.
You still can't see anything? All right. What am I doing here? What am I doing wrong? Thank you. That one. It's like, oh, because it pops up in a new window. Oh, that's kind of annoying. All right. So here, so yeah, so if it was flutter, you would see these little ripples along this entire anterior mitral valve leaflet. So this is a pretty crisp tracing. So I'm not seeing that fluttering. So you get little waves, little flutters like along the entire leaflet. So this was that B notch, which happens after the A wave. So this is, you know, again, you get an early closure of the mitral valve that causes that B bump due to elevated end diastolic pressures. SAM would be during systole. So this leaflet would get pulled up towards the septum. Prolapse again also happens during systole. You'd see a bowing back of, you know, this leaflet, an arching back or bowing back during systole as well. What was the other one? This guy. No. Sorry. This guy. Sharing, stop, share the screen. Okay. Yeah, it's making me like share each one individually. There we go. All right. So suprasternal notch view. So I can tell if I'm in the, so again, suprasternal notch, we're looking at aorta. That's the focus of our image. You know, we're assessing the aorta, looking for dissection, coarctation, dilatation, you know, again, dissection. So I can tell if I'm ascending aorta or descending aorta based on the direction of this arterial waveform. So again, if you just kind of think about it, your probe is there. My arterial during systole is going away from me. So I know I'm in the descending aorta. If I was in the ascending aorta, this portion would be towards my transducer above the baseline. So this is during diastole. I can see holodiastolic flow reversal in the descending aorta. And then this again indicates severe aortic insufficiency. Some of the other ones. These picture ones. This one. Yep. Yep. All right. So again, so just look at this tracing. So this is an aortic Doppler. So again, with our aortic Dopplers, normal flow during systole is going to be below the baseline. So when we want to look at like aortic stenosis and measure our peak velocities for aortic stenosis, you would adjust your baseline, you know, bring your baseline up so you get your full aortic valve outflow velocities, and then you can measure that. So this here, we're focused on our regurg of the aortic valve, which is, you know, back above the baseline. So here we're seeing a very flat slope that indicates a very long pressure half time. They tell us it's 842 milliseconds. So that would indicate mild aortic insufficiency. So if it was severe, this would be a very sharp decline, a very steep slope. That indicates a very short pressure half time. And it would be very bright. So this would be very, very echogenic. So like we'd see echoes like, you know, like this down here within that tracing. This is considered fairly faint. I mean, this is, you know, it's filled in, but not as bright as, you know, the actual outflow velocities that we see down here. So just again, don't get mistaken, you know, like for severe mitral stenosis. So this would look like, you know, a patient that had severe mitral stenosis, you'd see something like this. So if you were to plug this into your pressure halftime equation for severe mitral stenosis, this is like a valve area, you know, 0.25, you know, it's like a quarter almost. So 220 divided by 800, we're talking like, you know, like a valve area, that would be 0.2 something, you know. So that'd be a severely stenotic mitral valve. Any other ones to show you guys? Were there any other picture ones? I'm trying to remember. Oh, there was, right? There was at the beginning. So this is showing a pulse rate Doppler of the mitral valve. So here they're just tracing your mitral inflow and calculating the, so when you trace the mitral inflow like this, you're getting the VTI, and that calculates your mean pressure gradients as well as your max pressure gradients. So again, you have a mean pressure gradient greater than 10. So this indicates severe mitral stenosis. So don't even worry about the mitral regurg that you're seeing here. I think that was it for the pictures. All right. So you guys tell me when I'm not doing something right, all right? All right, have a good weekend. It's after 4. Thank you for staying on.
Thanks. Have a good weekend.
Yes.
Bye.
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 Have a good weekend.